network. Can you hear me, Rachel?
Yes, I can. That's brilliant. That's brilliant. So welcome everyone to Hidden in Heart Failure, which is the second of our webinars in this Rare Disease Notebook series, which is a joint venture between the South London Cardiovascular Networks and the South East Genomic Medicine Service, and intended for anyone who's interested in rare disease. We're starting with inherited cardiac conditions, but hopefully moving on to other disease types later in the year. No prior knowledge required, and we hope it's of interest broadly to you. So I'm not going to talk for long because we've got lots to cover. We've got some excellent speakers. Just to say, please, if you have any questions, do add them to the chat as we go through the talks. And we will probably keep questions till the end of the session because we've got a lot to cover. If there's time, we can do some in between. But to start us off, I would like to welcome Professor Gerry Carr-White, who is going to speak to us about when to consider inherited causes of heart failure, with some tips for how to identify inherited conditions hidden within heart failure. So welcome, Gerry. Gerry's cardiologist at Guy's and St Thomas's Hospital and the founder of our ICC service there. So the floor is yours. Thanks, Gerry.
Can you see my slides okay, Rachel?
We can't at the moment. It's blank at the moment. There they are. Yep, they're there.
Lovely. And are they full screen?
Yes.
Brilliant. Great. Well, afternoon, everyone. It's a great program, and big thanks to Rachel, Andrew, and everyone that's put it together. So I'm just going to start with just a little bit about what inherited disease is sort of hidden in our general clinics, in our heart failure clinics, in our nurse-led clinics, because I think probably that there's quite a lot we do miss. So I'm just going to go through some broad outlines and principles that people can follow. So yeah, there's my disclosures. So I think that the first thing to say is these conditions, that they're not rare conditions. So if you look at the totality of inherited cardiac conditions, probably more than 1% of the population will carry a phenotype or a genotype related to these inherited cardiac conditions. And I just wanted to spend a little moment going through what we mean by inherited cardiac conditions. So probably the commonest is the cardiomyopathies. And I've just summarized these over on the left here. So you have hypertrophic dilated cardiomyopathy. You now have this non-dilated left ventricular cardiomyopathy, where function tends to be preserved, but you get this sort of concentric scar, this sort of white pattern going all the way around the left ventricle. You've got arrhythmogenic right ventricular cardiomyopathy and restrictive cardiomyopathy, which is a little bit rarer. But, hypertrophic and dilated cardiomyopathy, probably about 1 in 300 of the population if you really look for them. And then you have these inherited arrhythmias. So you have long QT syndrome, got the different types here. This ECG just underneath is a Brugada ECG. And at the bottom, we have these sort of bidirectional couplets when you exercise. So this is a CPVT, or a catecholaminergic polymorphic VT, where you tend to get arrhythmias or blackouts when you exercise. You then have these aortopathies. Marfan's probably the commonest one people have heard of, but there's a whole range of syndromic and non-syndromic aortopathies, again, that we probably do miss quite a few of those. And then we have the other conditions. So we have the sudden pediatric or adult death syndrome, where you have a sudden death with a normal post-mortem. There's a whole range of metabolic mitochondrial disorders, and probably the mitochondrial disorders are more common than we realize. There's neuromuscular conditions such as Becker's muscular dystrophy and some of the sort of the different limb girdle dystrophies. And just at the end, it's not, everyone forgets about this, but familial hypercholesterolemia, probably, I don't know, 600,000-700,000 of those cases in the country, and we're only picking up about 20% of them. So that's the totality of inherited cardiac conditions. And that's just a little list to think about as you're seeing different patients. Right, so I'm just going to pick up a few red flags. There's lots of red flags you can look for. But just, when you're seeing these patients, you just got to remember that diagnosis is determining the nature and cause of a disease, but a description is just describing what you see. And I think these are the three things I just want to comment and look at in the next sort of 15 minutes or so. So heart failure with preserved ejection fraction, dilated cardiomyopathy and complete heart block. Now, these are descriptions, they're not diagnoses. And all of those have a whole host of underlying diagnoses, a lot of which, can be genetic in nature. So whenever you're seeing patients with HFpEF, with dilated cardiomyopathy or complete heart block, go to the next level, try and find out what the underlying cause is. So if we start with dilated cardiomyopathy, so you can see here, we've got a list of boxes about the sort of underlying conditions there. I'll just play there. You can see bottom echo is a severe case of a dilated cardiomyopathy. The MRI on the top shows pretty preserved function, but again, volume's just a little bit high. So that's the other end of the spectrum there. So if we work our way through the different causes, you've got all the genetic causes, you've got infections, viruses would be the commonest cause. You've got the autoimmune causes, you've got toxic overload, you've got drugs, endocrine, metabolic, and peripartum. So in the real world, how do you try and tease those out? So there's just a few things to do, I think. Take a thorough history, look for red flags in terms of symptoms and signs. But then you want to take a proper family history, a 3-generation pedigree. You want to do an MRI to look for specific patterns of scar that might guide you towards one of these. There's a series of blood tests you do. So you would do a HIV, you do an autoimmune profile. Really important to do a CK to pick up some of the muscular dystrophies that can just present with a pure cardiac phenotype. And then you do an ECG and a Holter to look for disproportionate arrhythmias. So that's the sort of main thing you do, and perhaps a neurological exam as well to try and tease out some of these different causes. So if we just look at a few specific cases. So this is dilated cardiomyopathy with disproportionate arrhythmias. And they'd often have quite a bit of scar on their MRI, particularly around the left ventricle. So this is people where function isn't too bad, but they often have quite a bit of scar, and they'll have a high ventricular ectopy burden. They'll have runs of non-sustained VT on the Holter. And when you see that this is identifying a higher risk group. So you've got to think about the inflammatory causes. So there's some of the infectious causes. Sarcoid is a great mimicker, so always think about that. Giant cell myocarditis normally presents pretty acutely with, life-threatening arrhythmias, and normally that's the kind of thing you diagnose and try and biopsy when they're on intensive care. And here are the genetics. Here are some of the slightly higher risk genetic causes that we do want to pick up. And that's one of the reasons we do genetic testing in this group, because these would carry a higher risk and you'd have a lower threshold for considering defibrillators. And you can see here are the ones that give you the predominantly left-sided disease. And then there's some other ones that would give you more of an arrhythmogenic right ventricular cardiomyopathy type. You can see here, so this is the left ventricular form of arrhythmogenic cardiomyopathy, or this new non-dilated left ventricular cardiomyopathy. I've seen, I think, loads and loads of families now where they had a diagnosis of myocarditis, and now we're realizing actually they've got the genetic form of this left ventricular cardiomyopathy, because it can present quite acutely like a viral myocarditis. So you get these sort of infralateral T-wave changes, and get this sort of subtle or quite concentric left ventricular scar, big ectopy burden. So I think if you see someone who's historically labeled as a prior myocarditis and they've got a twitchy heart, they've got this left ventricular scar, I'd have a very low threshold for thinking about this left ventricular cardiomyopathy. Next group just to mention is the inflammatory cardiomyopathies and rheumatological disease. And these are a tricky group. So it's sort of the lupus, antiphospholipid, scleroderma, Churg-Strauss is the old name now. But they often have a combination of factors. So they can get an inflammatory myocarditis, they get premature coronary disease, often by about 10 years. They can get in situ thrombosis, microvascular infarcts. An MRI is a really helpful thing to do in these patients. But I think, you know, if you've got any symptoms, have a very low threshold for looking into this. And I think all the different autoantibodies are difficult these days, aren't they? So probably the easiest thing, if you're worried, is just to ask a rheumatologist to see them. Okay, and then just moving on to sarcoid. Again, I think this is something we do miss quite often. So multi-system disorder, but if you're seeing ventricular tachycardia or higher degrees of heart block, do think of cardiac sarcoid. Panel on the left just shows that it can mimic almost anything when you look at the MRI scans. It can look like a small segment cardiac infarct, full thickness, look like an arrhythmogenic cardiomyopathy, can look like ARVC, can look like patchy myocarditis. So all of those cases due to sarcoid. And here in the middle, we've got an FDG PET scan. So I think MRI is good at looking for scar. The FDG PET's very good at looking for active inflammation, which you would immunosuppress. But the other thing, if you look on the right, is it can pick up these nodes. So if you want a histological diagnosis, often the best way is an endoscopic ultrasonic biopsy of these nodes. So an EBUS is often the way to pick up and make the diagnosis. So always remember sarcoid. And then I think people will come on to this, but just a little bit about mainstreaming genetics here. So we used to think that genetics was always autosomal dominant, and you either had it or you didn't. But actually these days, you can get incomplete penetrance or these intermediate or common variants all coming together with environmental factors, such as, you know, exercise, smoking, hypertension, and all of that. So it's a much more complex arena, but this is very relevant when you hear the next talks about who we should be screening and how often. Okay, just moving on to heart block. So again, heart block is a description, not a diagnosis. So it can be due to all of these things, but I'm just going to focus on sarcoid, which I've talked about. But these lamin cardiomyopathies. So if you take patients with dilated cardiomyopathy and complete heart block, about 25 to 30% will be due to these lamin mutations. And basically the common theme here is dilated cardiomyopathy with conduction disease, with or without evidence of skeletal muscular dystrophy. And the reason lamin in particular is important is the event rates are very high. So in the early series, when you have non-sustained VT or LV impairment or a truncating mutation, you know, over 50% were either having appropriate shocks or dying. So it's a very high risk disease. And if you look over on the left, you can see the arrhythmias predate the cardiomyopathy by 2 to 4, 5 years. And what that means is you're getting the life-threatening arrhythmias before your ejection fraction drops. So the common scenario you see with lamin is families where people are dying with pacemakers in because they get the complete heart block. Ejection fraction's normal, so they don't get a defibrillator. And then they get their VFRS. So if you ever see that in a family, that's a big red flag for the lamin cardiomyopathy. Okay, and then yeah, one of my bugbears. So HFpEF, I'm just going to finish on the last few slides. So this is, for HFpEF, you have to have symptoms and signs of heart failure with a normal ejection fraction, and then you have to have a raised BNP, but also echo or MRI signs of elevated filling pressure. And then when you manage it, so you diuretics for fluid retention, DAPA or empagliflozin, yeah, good evidence now for Manjaro, actually, if you're overweight. And then you've got to treat all the comorbidities. And here are all the comorbidities, and you can see there's a huge lot of those. But HFpEF, again, is a description, so it covers a multitude of causes. And here are some of the ones to really look for. So obviously, at a population level, hypertension is the biggest risk and the one to treat. But HOCM can present as HFpEF. AL and TTR amyloid can present as HFpEF. Fabry's disease, mitochondrial disease, some of the rare storage diseases. And you can see on the bottom, that's the age at which they'd present. So look at the age the HFpEF is presenting and have a good look for these underlying causes, because a lot of these are treatable, or will give you a different risk in terms of devices and other treatment. So TTR amyloid, again, can be genetic in a proportion of cases. And if you look at those undergoing TAVI, up to 16% will have TTR amyloid. And the way to diagnose that is you exclude AL amyloid, so you have to do serum and urine immunofixation and light chain ratio. And then if you do a DPD scan or an MRI scan, you can nearly always diagnose it. And that's just some of the typical signs of amyloid, which I'll whiz through because of time. And it's an exciting area for amyloid because we've got all these different treatments coming through. So suppression with gene silencing, that's coming through. Tafamidis is now available to prescribe for stabilizing it. And for those with more severe disease in the future, you'll be able to get it with monoclonal antibodies to the fibrils. And here's two of the recent studies. So significant effects treating TTR amyloid, both in terms of quality of life and hard outcomes like mortality. Okay, aortopathies, here's some of the people to think about if you see them in your clinic. So young aneurysmal dissection, family history of young aneurysmal dissection, and then some of the systemic features of Ehlers-Danlos, Ehlers-Ditz and Marfan. So again, have a low threshold for anyone who's particularly had surgery on their thoracic aorta. If you see a family where there's young sudden deaths and you look in the wider family, you can find a genetic cause maybe up to 40% of the time, particularly if you do genetics on the people that have passed away. So if you see families with young deaths, you just make sure the first degree relatives are screened. And then final slide, so familial hypercholesterolemia, this is really common, and we're picking up, as I said, 15 or 20% of this. So if your total cholesterol is over 7.5 or LDL is over 4.9, if you've got any of these signs on the right, you can see here with tendon xanthomas, obviously if there's a genetic mutation. And if you've got premature infarction, less than 50 in a second-degree relative or 60 in first-degree relative, or family history of raised cholesterol, put those together and you can try and get a reasonable likelihood of whether they've got familial hypercholesterolemia. Okay, so just in time. So yeah, in conclusion, yeah, just the one thing to take home, I think, is if you see patients with dilated cardiomyopathy, HFpEF and complete heart block, look for the underlying potential inherited disease behind it. Don't forget TT amyloid and familial hypercholesterolemia. Okay, lovely. So thank you very much for your time. And I think, Rachel, we'll leave questions to the end, won't we?
Thanks, Gerry. Yes, to leave questions to the end if that's okay with you, but thanks very much for that great overview of inherited cardiac disease, and hopefully lots of food for thought then for people to think about when they're seeing patients generally, but particularly those with heart failure. So thank you very much. I'm, in the interest of time, going to move sort of straight on to introduce our next speaker, Dr. Dan Hammersley, who is a cardiologist based at King's College Hospital in London. And Dan's going to talk to us about screening, so screening for patients with inherited heart muscle disease, and how we think of using clinical and genetic testing to do that. Thanks, Dan.
Great, thank you, Rachel. Can you see my slides, firstly?
We can, thank you, yes.
Great. Well, thank you for the invite to speak. It's a great pleasure to talk today about screening for inherited cardiomyopathies, focusing on clinical and genetic aspects of screening. I'm going to cover this firstly by looking at the prevalence and genetic basis of inherited cardiomyopathies, and then focus on the incidence of cardiomyopathy in first-degree family members from data that we have. We're then going to explore what cardiomyopathy screening is and what the current guideline recommendations are for screening, consider the benefits of screening and look at how effective it is. And I'll finish up with a couple of special considerations and a very brief case example. So there's lots to get through and I'll move through fairly swiftly now. Fantastic talk from Gerry, and you've seen this this schematic already from the recent European Society of Cardiomyopathy guidelines, illustrating that these cardiomyopathies are a group of genetic heart muscle diseases. They're classified by phenotype. And I really just wanted to reiterate the population prevalence of these conditions, just as a mechanism for illustrating the significant number of family members who may be also at risk of these conditions. And that you've heard already, hypertrophic cardiomyopathy and dilated cardiomyopathy really are quite common diseases. And depending on which paper you look at, the population prevalence is probably 1 in 250 to 1 in 300, as Gerry said, for these conditions. We don't really know what the population prevalence of non-dilated LV cardiomyopathy is at the moment because it's only recently been defined. And then arrhythmogenic right ventricular cardiomyopathy is a little bit rarer at about 1 in 2,000. We recognise that that many of these cardiomyopathies are genetic diseases, and in some cases these are monogenic diseases, so diseases caused by a single gene variant. And the most common mode of inheritance of monogenic diseases is autosomal dominant inheritance, which means that patients who are affected have a 50% chance of passing on the gene abnormality to their offspring. And if you now consider the population prevalence of these cardiomyopathies, particularly HCM and DCM, a reasonable conclusion is that there's going to be a very significant number of first-degree family members who may be at risk of developing cardiomyopathy in the future. Added to this, we now recognise that there are several cardiomyopathies that were previously considered to be acquired cardiomyopathies, which actually have an underlying genetic contribution that is similar to the other cardiomyopathies that we see. So, for example, peripartum cardiomyopathy, cancer therapy-induced cardiomyopathy, and alcohol-related cardiomyopathies often have an underlying genetic basis, further adding to the pool of potential first-degree family members who may be at risk of developing these diseases over the course of their lifetime. So, what is the incidence of cardiomyopathy in first-degree family members of patients with cardiomyopathy? This is difficult to establish because it requires large numbers and long-term follow-up, and that's technically difficult to do at scale. This is a study published a few years ago in JAMA, which was based on 25 US heart failure programs, just over 1,200 probands with DCM and 1,700 first-degree family members of those probands. And this identified that there was a familial etiology of DCM in about a third of the families. And over the course of the lifetime of the first-degree family members, there was a risk of about 20% of developing dilated cardiomyopathy and about 30% if you consider early phenotypic forms of dilated cardiomyopathy. So it's a fairly substantial burden over the course of a lifetime for those first-degree family members. And this doesn't take into account patients with known or first-degree family members with gene variant carriers. And actually, it's a logical conclusion to assume that in family members who carry the gene abnormality but don't have the abnormal phenotype, that these family members may be at a higher risk of developing cardiomyopathies over the course of their lifetime. And this was a study from the Bart's group that showed exactly that. This was a study of 285 first-degree family members of patients with sarcomeric hypertrophic cardiomyopathy caused by a sarcomeric pathogenic or likely pathogenic variant. And these family members carried the gene variant but did not have a phenotype consistent with hypertrophic cardiomyopathy at the point of their first assessment. And when you followed these patients up for over the long term, you see a penetrance, development of hypertrophic cardiomyopathy in 46% of these gene carriers over 15 years. And actually, patients who are male and those who had an abnormal ECG at the point of their first assessment appear to have a higher risk of developing hypertrophic cardiomyopathy. So, on the basis of that, you can see the potential rationale for offering screening to first-degree family members who may be at risk of developing cardiomyopathy. And cardiomyopathy screening is indeed the non-invasive testing for cardiomyopathy or for early phenotypic features of cardiomyopathy, which is routinely recommended for first-degree family members of patients with cardiomyopathies. Really, there are two forms of screening that can be offered. The first is clinical screening, which involves taking a history to check for symptoms, but then some basic clinical tests, which would routinely be a 12-lead ECG and an echocardiogram to look for evidence of cardiomyopathy. And in some cases, one may do a cardiac MRI instead of or in addition to an echocardiogram, and plus or minus consider some other clinical investigations. Now, the second type of cardiomyopathy of screening that can be offered in selected families is predictive genetic testing. And this can be offered to first-degree family members where there is a recognized and established genetic cause of the cardiomyopathy within that family. And what this effectively is targeted genetic testing to see whether a first-degree family member carries the gene abnormality within that exists within the family that is associated with cardiomyopathy. So which first-degree family members should have which type of screening? Well, for those in whom the family has no disease-causing genetic variant, these first-degree family members would be eligible simply for clinical screening. And the circumstances under which that may occur is either because the proband has not had genetic testing, or it may be because they've had genetic testing and that's not found a genetic cause for cardiomyopathy. But in those families in whom there is a disease-causing genetic variant established within the family, the first-degree family members can have clinical screening and then predictive genetic testing, provided there's robust evidence confirming that that genetic variant is associated with disease. So if we consider the clinical relevance of screening and the time point at which it can that it may be relevant within the natural history of cardiomyopathies, it's now recognized that many patients have a pre-phenotypic phase of disease, which may exist when patients are not exhibiting really any significant phenotypic features of disease, but have an underlying genetic risk. They may be genotype positive, phenotype negative gene carriers. Then through early adverse cardiac remodeling, early disease expression occurs with the formation of early phenotypic changes. And then through progressive adverse remodeling, patients may develop cardiomyopathies with symptoms. And as you progress through this natural history of progressive myocardial disease, the risk of adverse cardiovascular events increases. And if you think about a hypothetical situation where we didn't offer any screening to family members, we would only find out about cardiomyopathies at the point of patients or of the family members developing symptoms if they did develop cardiomyopathy. If we offer clinical screening, it's possible to detect early phenotypic features of disease, as well as patients who have previously undiagnosed cardiomyopathy that meets full diagnostic criteria for cardiomyopathy. And if we consider predictive genetic testing, it's possible to identify patients in a pre-phenotypic phase of disease. So why do we do screening for cardiomyopathies? Well, it identifies patients early who can be put into surveillance programs. And it's important to note that these patients are not entirely without risk, even sometimes in the pre-phenotypic phases. And certainly in the early phenotypic phases, there can be a risk associated with these. So it allows time and the ability to undertake more tests to attempt to risk stratify these patients. And under certain circumstances, it can permit early initiation of treatment. And that may be with conventional therapies that we have now, And in the future, there's a lot of interest in this group who we recognise have a significant risk of developing cardiomyopathy in the future, particularly in light of cutting-edge advanced therapies such as gene therapy that may be able to terminate that natural progression of myocardial disease that we tend to see at present. So in terms of the guidelines, if you have a family in whom there is a gene variant that's been identified and associated with disease, if we test a first-degree family member via predictive genetic testing and they don't carry the variant, these patients can typically be discharged if they don't have the phenotype. If a first-degree family member has the gene variant but doesn't have a phenotype, so genotype positive, phenotype negative, these patients would have long-term follow-up typically, and the time intervals with which one may do that would depend upon the gene, the family, and the individual. But typically in younger patients, less than 60, you may follow these patients up with interval cardiac imaging every 1 to 3 years and then increase that length a little bit after the age of 60. If you look at the right-hand side of this flowchart now, for those patients in whom there's no genetic diagnosis in the family, first-degree family members will typically be entered into a clinical screening program that recurs cyclically at regular time intervals, for example, every 3 to 4 years during adult life. And you might want to tailor that depending again on the individual family. For example, if there's clearly familial disease, but there was never a genetic diagnosis made in the proband, then you may want to consider more frequent time intervals for follow-up. Whereas if there's simply isolated disease despite screening of family members, then it may be possible to terminate screening at an earlier time of 50 or at an earlier time point at the age of 50 or so. I wanted to show you this slide because these are the guidelines for screening family members of patients with cardiomyopathy. And the purpose for showing you this is if you look at the right-hand column, the level of evidence that the recommendations are based on is almost exclusively level C. And what that means is that it's based on consensus opinion of experts and small studies. So really, this is an area that we don't have high-level data on, and something that I'd very much like to see improve in the years to come. And it's certainly an area that we simply don't have large-scale studies to support what we do at the moment, unfortunately. So how effective is cardiomyopathy screening? Well, this was a study from Jack, published a few years ago, which was a retrospective study of just under 600 first-degree relatives of patients with dilated cardiomyopathy. And what this shows is that actually you get the most bang for your buck from the first assessment of the first-degree family members rather than the sequential follow-on assessments that you do every few years. And in this study, at the baseline assessment of first-degree family members, 22% actually had dilated cardiomyopathy. And then if you combine that with what you obtain from predictive genetic testing, you have a third of family members who either have DCM at baseline assessment or who are genotype positive, phenotype negative. And there were 10% who'd had predictive genetic testing and didn't carry the familial variant in this study who could be discharged from follow-up. And actually, this shows that the incidence rates of developing dilated cardiomyopathy over long-term follow-up is quite low, about 2% per person year. And again, as with the earlier studies, subtle abnormalities at the baseline assessment seem to portend a higher chance of developing cardiomyopathy in the future. So that's why it's important to look out for those on ECG and echo. Of course, we live in times where we're all under pressure to be as efficient as we can with resources, and the screening programs do represent a significant challenge for that, because these patients will, many of them need to keep coming back every few years for many years, decades. And so it's important to consider whether we can identify lower risk groups to guide clinical screening. This was an interesting study, again, from Jack, that looked at patients who were first-degree family members of patients with hypertrophic cardiomyopathy who were gene elusive, so who'd had a genetic testing that was negative. And actually, this showed that among 750 first-degree relatives of such patients, only 5%, so a very low proportion, had a diagnosis of hypertrophic cardiomyopathy at baseline. And only two patients in this study, only 2 relatives in this study developed hypertrophic cardiomyopathy during 5-year follow-up. So these may be the type of families in which one might be able to rationalize screening because they're low risk. And actually those family members who did develop hypertrophic cardiomyopathy had mild phenotypes with low symptom burden, and none of them had cardiovascular events over long-term follow-up. So I just wanted to finish up by looking at screening in arrhythmogenic cardiomyopathy, because this is slightly different. So arrhythmogenic cardiomyopathy is characterized by the presence of scar and ventricular arrhythmias. Scar's not seen on echocardiogram, and you won't see ventricular arrhythmias on a 12-lead ECG. So because of that, we recommend a cardiac MRI scan and Holter monitoring for screening first-degree family members of patients with arrhythmogenic cardiomyopathy. And you can see on the left-hand side, this is a patient who actually was screened and had a normal echocardiogram, but then had a cardiac MRI which showed extensive scar, as illustrated by the red arrows. And then when a Holter monitor was done, the patient had non-sustained ventricular tachycardia and actually does have arrhythmogenic cardiomyopathy. And I wanted to finish up by illustrating the value of screening in a family that we look after at King's, who we saw last year. So this is a 34-year-old patient, it's indicated by the orange arrow, who was referred for screening after his sister was diagnosed with dilated cardiomyopathy that was on the arrhythmogenic cardiomyopathy spectrum, and had syncope and had a device implanted at another institution, and was found to carry a pathogenic filamin C mutation, which is a very malignant form of arrhythmogenic cardiomyopathy. So we did a 12-lead ECG, which was unremarkable in this patient, and actually an echocardiogram, which was largely unremarkable too, but referred this patient for a cardiac MRI scan, which did identify scar on the lateral wall. And the patient underwent predictive genetic testing, which found that he was positive for a pathogenic filamin C variant. On the basis of this, we reviewed the patient at MDT and offered this patient actually a defibrillator, which he had last year. And in parallel to that, he went through pre-implantation genetic testing, as he wanted to start a family. The reason I wanted to illustrate this case is because he actually contacted us last week to say that he had had an appropriate shock from his defibrillator after going into ventricular fibrillation. So it's a good case because it illustrates the power of advanced imaging and genetic testing for identifying very significant disease, which would otherwise likely have resulted in this young man having a sudden cardiac death. And actually, in tandem with that, he also let us know that his wife was pregnant with a child for whom the chance of inheriting the filamin C mutation has been eliminated through pre-implantation genetic testing. So it's a good case that shows both the power of screening, but also the collaborative work within inherited cardiac conditions and lots of related specialties. So I'm going to finish up and summarize by saying that screening for inherited cardiomyopathies is recommended for first-degree family members of patients with cardiomyopathies. We talked about clinical screening versus predictive genetic testing. The rationale for doing it is that screening can permit early identification of patients with cardiomyopathy, which can allow enhanced surveillance and in some cases early treatment initiation. The identification of family members who are at high and low risk of developing cardiomyopathy remains a challenge and is an important unmet need. And really, there's quite a substantial lack of data supporting our current practice. And finally, the early identification of these phenotypes, I think, will become increasingly important, and I hope that is in the context of an ever-expanding armamentarium of cutting-edge treatments and possibly one-day gene therapies. But that's very much something to watch this space. So thank you again for the invitation to speak, and be delighted to take questions at the end.
Thanks, Dan. That's a lovely case, and thanks for navigating us through the complexities of screening, which can be challenging. So lovely. Please do, everyone on the call, please don't feel frightened to add any questions to the chat. I hope and think we will have time for those at the end. In the interim, though, I'm going to move on to our final speaker, who I'd like to introduce, Liz Wilson. I think Liz is here on the call somewhere. Liz is going to talk to us about genomic testing for heart failure. Liz is based at the Liverpool Heart and Chest Hospital and is a inherited cardiac conditions clinical nurse specialist there. I'm pausing because there you are. Liz, can you hear me?
I can. Can you hear me, Rachel?
I can. Brilliant. Welcome. Nice to hear you.
Thanks so much for having me. I'm just going to check, are my screens cooperating with the presenter mode, or do I need to flip them before I start?
You just need to flip it. That's it.
Better?
Yeah, perfect. Perfect.
Fantastic. Thank you so much for having me. I've got the extremely difficult task of following on from Gerry and Dan's amazing talks, but I'll try my best. My name is Liz. I'm a clinical nurse specialist in inherited cardiac conditions, and I'm going to be talking just briefly about more of the practical elements of genetic testing in relation to the heart failure cohort. Apologies. So I'll be just in summary touching upon briefly about why genetic testing is useful, but I know that Gerry and Dan would have gone into those more detail, and I'm sure more eloquently. When is the right time to test and how to access genetic testing? So I like to start with a quote because I'm philosophical at heart. And I think when we think about genomic medicine in general, Prof Francis Collins summarises this very nicely in that genetics is the future of medicine. I think what's missing from this quote is the fact that as well as treatment and cures for these conditions, actually we're at a point now where we can eradicate the conditions within families, as Dan summarised in terms of pre-implantation genetic testing, for example. So it's just to reiterate the transformation in healthcare over the last few years in regards to genomic medicine and the huge impact that can have on our families. Thankfully, the powers that be or were agree in the potential for real and positive change, particularly in regards to inherited cardiac conditions, including conditions such as cardiomyopathy that can lead to heart failure. This has been embraced by NHSE through their NHS strategy, which was published in 2022. I won't go through everything that's outlined on the slide, but I think everyone on the call will probably be thinking how ambitious that is. Over the next 5 years, change is slow, but ultimately this is the change that needs to happen in order to provide not just high quality, but equity of access for our patients nationally as well. So in terms of the when, Gerry and Dan have spoken about a number of inherited cardiac conditions that involve an element of heart failure and or risk, along with suspicions, or when we should be suspicious of an underlying genetic component when a patient presents with a heart failure of unknown etiology. And the 2023 ESC guidelines and the National Genomic Test Directory referenced here also provide a lot of guidance and information about when to consider genetic testing. I've very much focused in on dilated cardiomyopathy for my talk today, but accepting there are lots of different types of inherited conditions that have their own R code in terms of testing, but just using this on the right as an example. It's meaty and it looks like a lot, but when you break it down, there's a lot of common sense in there in terms of having unexplained heart failure, family history, young onset, all those kind of triggers, those red flags that make you think this could be exploring from a genetic perspective. Dan's already touched upon this, so again, I won't dwell on this slide, but it's just to reiterate, is another element of the ESC guidelines in terms of special populations and the second hit theory when we're considering genetic testing. Gone are the days where we would say that somebody that had an alcohol problem or chemotherapy or simply by being pregnant, it's not suspicious for them to have a cardiomyopathy associated with that, in comparison to others that don't ever have signs of a cardiomyopathy. I think it's really important that we think outside of the box in terms of the second hit when we're looking at genetic heart conditions, or the potential for genetic heart conditions in families. Another quote here, and I think consistency in considering genetic testing as part of everyday care for patients is really so important. And in reality, inequity actually already exists in genomic medicine, which I think the genetic community has realised and is starting to respond over time. But as I said earlier, change is slow. And the quote here is from the NHS Race and Health Observatory. And I think it just summarises the importance of benefiting all patients at risk of underlying genetic predisposition to disease, including conditions such as cardiomyopathy that can cause heart failure. And of course, not just them, it's the impact on their family as well. In terms of the how, when we talk about genetic testing, it often feels like it's a very overwhelming topic, and I'm not going to make that, not going to sugarcoat it or make it any easier, because where there's a suspicion that the patient's heart failure may be genetic in nature, and genetic testing is being considered, there are important elements and considerations to address prior to testing. The practicalities are that DNA can be extracted from a blood or saliva, so body fluids or even tissue, to send to one of our genomic laboratory hubs, of which there are 7 demonstrated on the right, for gene sequencing in relation to genes where changes or variants are known to be associated with, for example, dilated cardiomyopathy. And this process has a turnover of several months, but doesn't include counselling or consenting of the patient to prepare them for the potential results. And I think when we're sending out a test, that's extremely important to remember. There are a lot of factors that can be a difficult conversation with patients, including the implications for family and the implications on themselves. But of course, the upside is the benefit of tailoring treatment and being ahead in terms of risk for the family. Having a good understanding of genetics and being able to educate on why and how we do genetic testing, as well as taking a detailed family history. And of course, there's always the dreaded secondary findings. A good example of this is neuromuscular conditions, where they may well have a dilated cardiomyopathy, but they're at risk of having other things. The key message here is that there is a rising genetic community within cardiology to support those that are not exposed to genetic testing as part of their everyday role. And I'll speak more very briefly in a couple of slides about education, as well as how to access local inherited cardiac conditions services and genetic services in order to help with this. So I don't want anyone to feel too overwhelmed. In terms of after the testing, of course, there's what we do with the very scientific genetic testing lab report that comes back, and results may be clear-cut in the sense that we find a gene that has a change or a variant that is very convincing in terms of the underlying cause. But then, of course, there is the next step of work, which is how we communicate that back to patients and their families in order for families to access predictive genetic testing, as Dan touched upon. There may be opportunities for prenatal or family planning conversations to protect future generations from inheriting that gene variant as well. And one thing, or one element that I love about my role in ICC is that you're never alone. It's a multidisciplinary team effort, including the expertise of genetic counsellors, geneticists, clinical scientists in the lab working along the cardiology community. So as with most elements of healthcare, there's a clear advantage to getting to know your local ICC team and working on pathways with them if you don't have them within your where you're working. And going back to that slide at the beginning about the NHSE strategy, it isn't just tertiary care, this is primary, secondary care as well. So we're in this together. In terms of help with that, we do have a directory of ICC services if you don't know who your local one is. I'm not supposed to call it the Association for Inherited Cardiac Conditions anymore because their name has changed, but they are still sorry, I don't know why that went on. They are still online as AICC, so you can search for them and you can actually access a directory to look up local services to contact for advice. If you're intrigued in regards to potentially thinking about setting up genetic testing within your own service where you don't have easy access, for example, to an ICC service, or if you feel that strongly enough that you see enough patients to do it yourself, there's tons of education out there. I've put on a handful of many, and I think that these are really great resources, both informally or sort of self-directed study, but also more formal programs in order to prepare us for the future in terms of genetic testing for our patients. That's everything. I hope I whizzed through that as quickly as possible so we had time for questions, but thank you so much. My contact details are there if you have any questions.
Thank you, Liz. That's a great talk and lots of good pointers, education and resources. Thank you for the plug for the AICC, just to let everybody know that that's that the name change is happening over the next few months and will be rebranded as BICS, the British Inherited Cardiac Conditions Society, but there will still be the service directory, and the website will point you to the new named organisation in due course. But thank you very much. I wonder if I could invite our 4 speakers back to the screen, as it were. If you don't mind popping your cameras back on. I can see we've got a question for Dan from Andy here in the chat. So Dan, it was around family screening, age of starting for children, and then is there a period or a decade of life that you would stop screening because the yield drops?
Thanks, Andy. Yeah, no, it's a great question. I think honestly we don't have much data to support what we do on this, as with a lot of it. But and it depends on the individual family and the disease and what the clinical course of relatives have been. But I think if you've got malignant disease with sudden deaths, particularly, then the earlier the better in children, really. And you know, I've got quite a low threshold for you know, recommending that these are on the books of the pediatric team under those circumstances. I think it's harder with the you know, milder phenotypes, and you know, I think in under those circumstances later on in childhood or early adolescence potentially. But again, as I say, it's a bit of an evidence-free zone. And in terms of in terms of the stopping screening, so the kind of incidence curve is sort of generally sigmoid shaped, and it kind of plateaus out after the age of about 60. So sort of local guidelines that we follow would generally say that unless there's clear familial disease or it's a pathogenic a G positive P negative patient, that we might consider stopping screening after the age of 60. If it's clearly familial or they've got a gene and not expressed a phenotype yet, then potentially continue on over the longer term. But there's quite conflicting data about this actually, and that paper that I presented from, or that figure from JAMA, does show that people do manifest with genetic cardiomyopathies even in old age. And there was another paper which showed that Titin cardiomyopathy, the most common cause of DCM, can manifest in DCM with onset in older age as well. So I would say watch this space. That tends to be the how I kind of approach it. But yeah, I think it can be challenging, and it's tailored to the individual family and the disease within the family.
Thanks, Dan. Yeah, and sort of comes back to that point you made nice in your presentation, that a lot of what we do is based on expert opinion, isn't it, rather than hard facts and evidence. Gerry.
Yes, it's a great question. Sorry to jump in. It's a great question, Andy, but because in a cash and resource limited NHS, we are using so much resource for this family screening. So I guess I had a few points. So one, Caskey's work shows it's the young Hocoms that we should probably see a bit earlier. So I think it's worth seeing kids, family members of Hocum patients are probably at 5 to begin with, because there is a cohort that presents them. But beyond that, we've got to find a way to discuss risk with patients, because in the same way, if your Q risk is less than 10%, you don't have a statin. People are having echoes and ECGs and ongoing psychological worry every 3 years for 4 decades, with a risk that's clearly less than 5% for anything happening. So I think it's we've probably got to move to personalized medicine, and AI and big databases will help this, where we can personalize when to screen, as Dan says, based on the genetics, the family history, the other comorbidities, and the patient's preference and their acceptance of risk, with a clear PIFI related how to come back into the system. So I think there's so much wasted resource. We do need a refresh, and I think we're going to try and come up with some statement through BICS, but it's just more of a discussion statement. I think the days of fixed rigid you see there and then is probably got to change, I think. Anyway, sorry, Rachel, I just, as you know, it's one of my bugbears.
No, it's a minefield, isn't it? And perhaps one day we'll have a national program and a national plan. That would be helpful, I think, as well. Question for all of you, really, from Tommy in the chat around DCM. Given the fact that there's a second hit and the genetic environmental overlap theory, should we consider a DCM panel for all of the patients with DCM who meet testing criteria via mainstreaming, even when it's been attributed, their cause of DCM has been attributed to an acquired cause, such as those who've had chemotherapy or alcohol excess or myocarditis? Or should we be prioritizing those who are more likely to be gene positive based upon their phenotype, the family history, and an absence of the acquired causes? And again, resource, do we think that the GLHs will be able to cope with the influx of all of this DCM gene testing that may come out of this? Dan?
I think it's a great question, Tommy. It's really difficult. I think in an ideal world, if they meet the criteria, then it's not really possible to eliminate the possibility of monogenic disease under, where there's a clear environmental trigger. And I think in an ideal world, yes, but there's the competing concept of rationing, I think, here. And clearly, if there's higher risk patients with scar patterns that are typical for inherited dilated cardiomyopathy, then the need is much greater for those patients, and the yield, from my experience, it does tend to be a bit lower in those with an environmental factor. So I think it's that challenge balancing those two aspects.
Thanks, Dan. Liz.
So I'm at risk of being controversial here, but those that know me find that no surprise. But I think if we're realistic, in the UK, we're not scratching the surface of genetic testing for the people that that we could technically be prioritising, let alone the second hit patients. And I think the GLHs will curse me for saying it, but unless we flood the system and we get that resource and we get that money behind the increase in the influx of genetic testing that the future of genomics is demanding and an HSE strategy is demanding, then we're not going to get anywhere. So I'm very much in favour of, if we think that it's right for the patient, we should be sending that genetic test. I really hope there's no one from the GLH here to tell me off for that, but I think the reality is we live in a mainstreaming world, and we need more resource in the labs.
Just a quick follow on, Liz, for you. If you're a clinician or a specialist nurse, general practitioner, if you're seeing a patient with heart failure in clinic and you're not someone who's au fait with genetic testing, what do you suggest that person does? You know, where do they look for help, or who do they call upon beyond looking at the genomic test directory, which is there but sort of quite dry? Where would you recommend they reach out to?
Yeah, and it's a great question, isn't it? Because all the resources out there, but it's buried in the thousand of other things or million other things on a Google search. And I think there is a huge value here in networking and having processes in place. We already have them in terms of advice and guidance systems that link primary and tertiary care, and I think, you know, focusing in on primary care, because they'll have the biggest battle here with genomic mainstreaming. We need to make sure those robust pathways are in place to enable people to come in to multidisciplinary team meetings, to advice and guidance, in order to speak to those of us that are exposed every day to genetic testing and they literally live and breathe it. But we need to make sure we put that infrastructure in to support others.
Thank you very much. I'm aware that we've just gone past 2 o'clock, and I suspect there are things to go on to this afternoon for everybody. So just want to finish up and say thank you very much to our 3 excellent speakers. Thanks so much for your talks. They've been great, really informative, and you know, thanks for joining us and sharing those with everybody. We have got another one of these next month, which is focused around aortopathy. We spoke a bit about aortopathy today, but please do come back and listen to that if you're interested. And for now, thanks everyone, and bye-bye.